One of the most important things, and you must have heard this many times, that time is myocardium, and therefore reperfusion needs to be done as soon as possible. Reperfusion, if done promptly, it limits the myocardial necrosis. This causes preservation of the LV function and reduces the mortality of the patient. So it's very important to do these things. Now, pre-hospital management is very important. Now, unfortunately, you said time is myocardium, and we know that the first 90 minutes are the most crucial after a ST-elevated myocardial infarction. But unfortunately, most patients do not seek care for the first 2 hours. So the most critical part, the golden hour, as we call it, most people don't even report to the hospital. When you have a chest pain, the correct thing to do is to take an aspirin and call the ambulance or go to the nearest facility which you already earmarked beforehand. If the hospital with the PCI center is close to you, that's where you should go. If the PCI center is not close to you, but a thrombolytic center is close to you, go there first. Let them stabilize you. Let them give you aspirin, clopidogrel, maybe thrombolize you, give you heparin, and then transfer you to a PCI center. So do not waste time trying to hunt for hospitals and doctors and is this the best hospital, best doctor, etc. Because by that time your muscle will be dead.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
So I can start now. Good morning, friends. I'm going to talk about acute coronary syndromes and some of the recent management of these acute coronary syndromes. For those who want to get further details, there's a very nice guidelines from the European Society guidelines in 2023 on acute coronary syndrome. So a lot of data is there, of course, in these guidelines. So those who wish to read more about them may do so. When we talk of acute coronary syndromes, we usually talk about two types, the non-ST elevated and the ST elevated. The ST elevated is very simple to understand. The ST segments are elevated, and this is a typical acute myocardial infarction. Your rise of ST segments, along with that, your biomarker elevation. It usually signifies a complete occlusion of the coronary artery, and it requires a very prompt immediate treatment. And then you have the non-ST-ACS, which can be divided into two groups, the unstable angina and the non-ST elevated myocardial infarction. And what is the difference between the two? Unstable angina, usually the cardiac biomarkers are not elevated. In non-STEMI, the biomarkers are elevated. So the worst is, of course, STEMI with complete occlusion of the arteries and ST elevation. A non-STEMI with a cardiac marker elevation, which is also urgent and requires prompt treatment. An unstable angina where the ST segments may be normal, they may be depressed, or they may be only T wave changes. There's no myocardial necrosis so far. The cardiac enzymes are normal, and you have a little more time to decide management of these patients. So it's clearly important to define these three entities. And as you all know, cardiac biomarkers are very important. We first used to have creatine kinase, CK, MBCK, but it takes time. As you can see out here, MBCK takes about 4 to 8 hours to rise and peaks at about 24 hours and then remains for high for 48 to 72 hours. Whenever available now, of course, we have shifted to troponin, and troponin usually increases within 3 to 6 hours, peaks at about 12 to 24 hours, and remains elevated for 14 days. The HS troponin or the high sensitivity troponin is what we use now in almost all situations in major hospitals. The advantage of it is that rises very rapidly, and as I'll show you later, it can be very useful in making a diagnosis of particularly a non-ST elevated myocardial infarction. For example, if a patient presents to you with chest pain, which sounds very typically cardiac, but the ECGs do not show any significant changes, is a patient having a myocardial infarction or not is important. And in this situation, an HS troponin will quickly allow you to decide whether the patient is having an infarction and requires to be hospitalized and treated, or can rule out a myocardial infarction and be sent home. And the advantage of that is that whenever anybody presents to us in the casualty with chest pain, we usually have a chest pain protocol, which means that the patient has an ECG and, of course, clinical examination and a troponin done. If the ECG is normal, the patient is not sent home. It's very important to remember that the first ECGs, as you know, will be normal. So the patient is kept in the hospital for 2 hours. There's a repeat ECG, a repeat clinical examination, and a repeat troponin measurement. If the pain persists, or if the ECG shows changes, or the troponin is high, then the patient is hospitalized and investigated. If the troponin remains normal after 2 hours, the patient is free of pain and the ECG remains normal, the patient can be discharged to go home. Now, when you have acute coronary syndrome, the other common mimics of acute coronary syndrome are aortic dissections, acute pericarditis, acute pulmonary embolism, a pneumothorax, and esophageal perforation. So these are the things that we need to rule out. It's very nicely shown out here, AAPPPP. A is the acute coronary syndrome, aortic dissection, pericarditis, pulmonary embolism, pneumothorax, and esophageal rupture. And one of the ways to differentiate between that is the role of the CT scan. So when you do a CT scan, you can pick up most of these problems. Maybe not an acute pericarditis unless there is a tamponade or there's pericardial effusion, but the other conditions can easily be picked up. So sometimes when we are unsure in the emergency what to do, we do a quick CT scan to do a rule out of all these important conditions. And one of the most important things, and you must have heard this many times, that time is myocardium, and therefore reperfusion needs to be done as soon as possible. Reperfusion, if done promptly, it limits the myocardial necrosis. This causes preservation of the LV function and reduces the mortality of the patient. So it's very important to do these things. Now, pre-hospital management is very important. Now, unfortunately, he said time is myocardium, and we know that the first 90 minutes are the most crucial after a ST-elevated myocardial infarction. But unfortunately, most patients do not seek care for the first 2 hours. So the most critical part, the golden hour as we call it, most people don't even report to the hospital. Patients should know that when they have chest pain, they should take aspirin because that's one of the easy, prompt methods that would be beneficial. Best not to seek help here and there, not to wait for consultation in the evening, etc. Dial the ambulance, try and reach the hospital. Again, whether you come by yourself or you come through the emergency medical service, it's important that you try and find a facility that does angioplasty. Quick angioplasty and with either thrombolytic therapy or with PCI will produce a significant reduction of your mortality. So what I suggest to everybody and all the patients that come to me is that we should find out where you live and where you stay. Where you live and where you work, which is the closest facility available in case you have a cardiac problem. So you need to remember that when you have a problem, you should not go to a nursing home which has no facilities. You should find a nursing home which has at least an ICU facility and which does thrombolysis. And better still, the next place would be where they do PCIs. So when you have a chest pain, the correct thing to do is to take an aspirin and call the ambulance or go to the nearest facility which you already earmarked beforehand. If the hospital with the PCI center is close to you, that's where you should go. If the PCI center is not close to you, but a thrombolytic center is close to you, go there first. Let them stabilize you. Let them give you aspirin, clopidogrel, maybe thrombolize you, give you heparin, and then transfer you to a PCI center. So do not waste time trying to hunt for hospitals and doctors and is this the best hospital, best doctor, etc. Because by that time your muscle will be dead. Of course, risk stratification is important after because you have the ischemic risk, which I mentioned to you. And of course, ischemic risk and damage results in patients getting LV dysfunction. And then, of course, LV dysfunction produces an arrhythmic status. And as we know, ischemia also produces arrhythmias. And of course, the cause of death with myocardial infarction is often ventricular tachycardia and ventricular fibrillation. Now, LV function is very easy to assess, and fortunately for us in India, echocardiography is very easy to do. So, almost all emergency departments, all nursing homes have echocardiography facilities, which will help you to judge LV function and whether there's any associated myocardial dysfunction with valvular leakage, etc. As you all know, myocardial stunning is the immediate loss of myocardial function because of ischemia, and hibernation is chronic ischemia producing chronic myocardial hypokinesis. So it's important to remember that when the echo shows that the heart function is not good, in the acute phase, it may be just a stunned myocardium. And when you reperfuse that myocardium, the patient's myocardial function will improve. In a chronic situation where you have an occlusion of the artery, the muscle remains hibernated, that means not contracting. But when you supply blood to this muscle, the hibernating muscle becomes alive and myocardial function will improve. Of course, these are multiple slides from ESC. You don't need to go into all the details, but you can look upon them by yourself. So clearly, when the patient presents to you with chest pain, you do the ECG, as I mentioned, physical examination, take the history of the patient. It's important to know whether the patient had a past history of cardiac problems or not, any history of stroke, diabetes, blood pressure, etc. Vital signs, of course, most important. If the patient's in cardiogenic shock or hypotension, tachycardia, arrhythmias, you need to tackle them immediately. And then, of course, as I mentioned, you send HS troponin. You differentiate between STEMI, non-STEMI, ACS, and high-risk STEMI. And then, depending on that, you decide whether you should fibrinolyze the patient, immediate angiography. So, clearly, patients with ST elevation, immediate angiography, patients with ST depression, and raised troponins, again, immediate angiography. Only those patients who are non-ST elevated, not high-risk patients, troponins are still normal, you can delay the angiography and continue medical treatment. Other non-invasive investigations like echocardiography, in some cases, as I mentioned, CT to rule out other conditions, and then, of course, long-term treatment of these patients. So again, as I mentioned, is the abnormal ECG abnormal? Look at the clinical context. Is the patient young? Is the patient old? Has the patient got any background history of cardiac problems, family history of cardiac problems? And most important, is the patient stable? Because when the patient is unstable, hypotensive, then of course the treatment should be to immediately and promptly reverse the state. I mentioned to you about HS troponin. Again, HS troponin should be done at 0 hours. That means when the patient presents to you, and preferably at about 2 hours after the first episode. If the initial one is very low and it remains low, that rules out your problems and you can send the patient home. If the initial troponin is high and there's an increase in troponin, then of course the patient goes into further investigations, angiography, etc. For the middle of the line patients, you can observe these patients and decide what to do. But clearly, this is important for patients whose ECG do not show abnormality. Clearly, if the patient has chest pain and ST elevation, you don't even need an HS troponin. If the patient has chest pain and ST depression, again, you have your diagnosis. Troponins are very important for people who have cardiac-like chest pain, but whose ECGs are not diagnostic. So again, as I mentioned, HS troponin will facilitate rapid and better cost-effective care. So you don't send the patient home to then get an infarct at home, nor do you keep the patient in the ICU just to make sure that the patient is not missed out on anything. So chest pain clinics in the casualty are run all over the world and in most major centers in India as well. Of course, you know, the patients can present in multiple ways. As I mentioned to you, they can come by themselves to the hospital or they can call an emergency service. And again, very important, it depends on where the patient lands up. If the patient goes to a PCI center and the patient has got high risk factors, then of course you don't waste time in the casualty. In many hospitals, these patients are taken straight from the ambulance into the cath lab for immediate PCI. Because as I mentioned to you, the earlier the PCI, less the damage to the patient. If the patient, however, cannot reach a PCI center, then it's important to decide about thrombolizing the patient. So you thrombolize the patient and then you have time. And then that's called what is called as the pharmaco-invasive therapy. That means you give the thrombolysis and then you allow the patient to stabilize, but you don't keep the patient there. Once the patient is stabilized, you've given your thrombolysis, the patient must then be shifted to a PCI center. But you now have time to shift the patient. And then in the PCI center, the patient must have an angiography. All patients who are thrombolized must have an angiography. Some of them may need angioplasty, some of them may not need angioplasty. Usually, if the patient stabilizes after thrombolysis, there's no urgency to do the angiography. In the sense that if a patient comes in the with a ST depression in the evening, or ST elevation, sorry, not ST depression, ST elevation infarction, he's thrombolized, he stabilizes, the ST segments settle down, he's transferred to a PCI center, maybe say in the middle of the night. In such a patient, you could wait till morning before you do an angiography. Of course, if the ECG shows changes again, or the patient has symptoms again, then you do not wait and take the patient up urgently. So this is the pharmacoinvasive therapy. It has been extensively studied, particularly in southern India, where they've done a lot of this spoke and hub treatment of myocardial infarction. So a patient in a small village has chest pain. They are able to do an ECG at that point using WhatsApp and various other technologies. The ECG is transmitted to a bigger center. They make a diagnosis of myocardial infarction. The ambulance reaches the person. They thrombolize the patient because they're usually in a small place, not easy to get PCI. They're given thrombolysis, aspirin, clopidogrel, etc. And then while the treatment is going on, they're shifted to a PCI center where then they undergo angiography for further decision. So this spoke and hub center for people is very important because everybody doesn't live within a close distance of a PCI center. So what are the treatments you give to this patient when he presents with acute coronary syndrome? Of course, we all know aspirin. I would suggest that everybody should keep a tablet of soluble aspirin. Please remember, when you have an acute myocardial infarction, do not take enteric-coated aspirin because you want quick action. Soluble aspirin, 150 to 300 milligrams, crush it or dissolve it and take it immediately. Once you diagnose the myocardial infarction, then of course you can give clopidogrel or prasugrel or ticagrelor. We do not advise patients to take these drugs other than aspirin till the diagnosis is established. So basically, you will need an ECG before you diagnose and start treating with clopidogrel, prasugrel, or ticagrelor. Ticagrelor, of course, has now become very commonly used and very effective. It's more effective than ticagrelor. Now, of course, we have also what is called as cangrelor. Cangrelor is intravenous platelet inhibitor drug. So that's brilliant because now instead of giving oral drugs, you can give IV drugs. The advantage is if the patient's having nausea, vomiting, and cannot tolerate these drugs, or if the patient's rushed to the ICU, to the cath lab and needs immediate angioplasty, the drugs that you can do is start the patient with cangrelor, which will then give much more immediate antiplatelet activity. So cangrelor is getting more and more popular now. This is a trial which is called the SWIRA trial with the ticagrelor. It's a real-world data. Of course, a plateau trial showed the benefit of ticagrelor, but it's a real-world data of almost 45,000 patients showing that compared to clopidogrel, ticagrelor produced a significant benefit in terms of reduction of cardiovascular events. Then you have eptifibatide and tirofiban, which are GP2B inhibitors. They were very popular once upon a time when we didn't have prasugrel and ticagrelor, and were useful at the time when only aspirin was available. But now they're used less and less. The importance of these drugs is they produce immediate effect in terms of platelet activity, but they do have much more bleeding tendencies, and they're not used commonly at all. Of course, in certain patients, you need to give heparin or low molecular weight heparin. And this is particularly important for patients who are thrombolized. So you thrombolize them, you give them weight appropriate regular heparin or enoxaparin low molecular weight heparin, or even fondaparinux, which is once a day low molecular weight heparin. And this can be given so that the patient doesn't have a reocclusion while waiting for angioplasty, transport to PCI center, etc. Bivalirudin has often been used in the cath lab instead of heparin, but again, it's not so popular these days as it was once upon a time. So this, of course, shows the antithrombotic regime, as I mentioned to you. Aspirin and clopidogrel remain the most common use today. But instead of clopidogrel, you could use prasugrel and ticagrelor. In an acute situation where you want to have rapid effect, you can give cangrelor. Cangrelor is also effective when patients are going to go for surgery. For example, a patient who's undergoing to go bypass surgery, you don't want to give ticagrelor or clopidogrel because they're long acting, but you at the same time want to keep the patient on antiplatelet drugs while being prepared for bypass surgery. In such a situation, you can give intravenous cangrelor, and then when the patient is taken to the theater, it can be stopped and the antiplatelet effects wear off very fast. So this is the strategy, as we mentioned, for the treatment of acute myocardial infarction. But after myocardial infarction, after angioplasty, you have to decide also what to do. There's a lot of data about de-escalation of antiplatelet therapy, and de-escalation of antiplatelet therapy means how long to give aspirin, how long to give prasugrel or ticagrelor, and when to stop it is a long, multiple trials have been, and there's still not been any conclusive evidence. But let me show you a couple of trials. One was the Twilight trial. In this trial, after a PCI, so the PCI was done. These were high-risk patients undergoing PCI. They were given ticagrelor and aspirin. So aspirin was always given to the patient along with ticagrelor. But then at the end of 3 months, the patients were kept only on ticagrelor. The aspirin was dropped, and the other group were given aspirin and ticagrelor, and they were observed for 18 months, 15-month period first, and then an 18-month period. And what they found was that bleeding significantly reduced. But that's easy to understand. If you give two antiplatelet therapies, aspirin and ticagrelor, then obviously bleeding will be more compared to ticagrelor alone. The question is, will the patient have more ischemic events? And here's the answer. The patient did not have any more increased ischemic events. So the composite of all-cause death, MI, and stroke was not any different. So clearly it suggests that to reduce the bleeding, you can, after 3 months, stop the aspirin and continue ticagrelor. You can't stop ticagrelor and give only aspirin because that might not be sufficient enough to reduce vascular events. There's another trial called the TICO trial. It looked at NAES. NAES is the net adverse cardiac events. That means the worst benefits versus the bleeding. So that's the NAES, the net of the two, good and bad. And you can see out here with ticagrelor monotherapy, the NACE was 3.9, and with standard therapy, it was 5.9, so much worse. Major bleeding, as you can see, was much worse when you give aspirin and clopidogrel together. So the present concept is that when you do angioplasty, you start them off on aspirin and ticagrelor or aspirin and prasugrel, and then after 1 month or 3 months, depending on the patient's status, if it's an unstable angina, ACS patients, you might want to give for 3 months. If it's a stable patient with stable coronary artery disease, you could stop the aspirin after 1 month. And that produces a reduction of bleeding without any increase of ischemic events. Now, whenever you treat patients with antiplatelet drugs, there's always a possibility of bleeding. So you should also look at the bleeding score for these patients. So those who have increased chance of bleeding, you have to be more careful with them when you give them too many drugs. So patients who are the ones who are most prone to bleeding, I think if you remember 4 groups, then it's important. Age. The older the patient, more the chance of bleeding. The patient is anemic, more the chances of problems. If the patient has prior bleeding, again, very high incidence of recurrence of bleeding, and if the patient has CKD. So these are the 4 groups of patients who you have to be very careful when you give multiple antiplatelet drugs or antiplatelet drugs along with heparin or with oral anticoagulation. One of the good ways to reduce intervention-induced bleeding is to use the radial approach during the angiography and angioplasty, because a large amount of this bleeding used to be femoral bleeding, ephemeral hematomas, retroperitoneal bleeds. These have almost completely been eliminated by the radial approach. So, the suggested therapies to reduce bleeding, again, when you use anticoagulating drugs, please adjust them for body weight and renal function. It's very important, especially when you're using NOACs and renal function. Certain NOACs like dabigatran are excreted from kidneys, and therefore you be very careful when you have patients' renal dysfunction. Use the radial approach for all patients in order to reduce GI bleeding, which is the commonest bleeding you get when you're doing these procedures and patients are on antiplatelet drugs and other drugs, is to use proton pump inhibitors as prophylactic agents. Now, of course, there's another complex problem, which is patients who have myocardial infarction, but who also have atrial fibrillation. So what happens is that when you have an infarct and you put a stent, you want to prevent stent thrombosis, and therefore you have to give dual antiplatelet therapy, DAPT. And on the other hand, you have atrial fibrillation and a chance of stroke, so you have to give NOACs. So what happens when these patients come for plastic? And if you have to give DAPT, then you have to give NOACs. And when you give both, you can imagine the significant increase of major bleeding. There are, of course, number of guidelines. This is a whole guideline, but still effective in patients with elective PCI. You can give for 1 month triple therapy, and after 1 month, you just give NOAC along with either clopidogrel or aspirin. In patients with ACS and PCI, you give for 3 months, and then you give only dual therapy. Now, the question is whether you should give NOACs along with aspirin or NOACs along with clopidogrel. Either are fine. Most people find that aspirin is a problem and therefore tend to use clopidogrel with NOACs. It is wise not to give NOACs with stronger antiplatelet drugs like prasugrel and ticagrelor. So when you're using NOACs, it's preferable to use clopidogrel rather than ticagrelor or prasugrel. It will produce less bleeding. And then, of course, after 1 year is over, then they suggest only NOAC monotherapy. So you can even drop the aspirin or clopidogrel, even though the patient has had a PCI and a stent, and continue only NOAC monotherapy. But there will be certain patients with multiple risk factors, very high risk plasty like left main bifurcating stent, etc., in whom you may want to continue dual therapy with NOAC and clopidogrel or aspirin. But then, of course, you must remember that these patients are more likely to have bleeding. There are 3 major trials looking at that. One is the Pioneer AF with rivaroxaban, the Residual PCI with dabigatran, and the Augustus with apixaban. I'm not going to go into details of this, but again, clearly, as I mentioned, the approach is short-term triple therapy, and then after 1 month or 3 months, dual therapy, and then at the end of 1 year, only NOACs. So this is the guidelines for treatment. Again, since we are doing ACS, there are a lot of advantages of doing intravascular imaging. So there's a lot of debate about whether you should do OCT or IVUS and should you be doing imaging. Clearly, if you do imaging, it is of benefit because you know exactly what you're dealing with. You must remember that all myocardial infarctions are not necessarily plaque ruptures and the typical myocardial infarction, which you get plaque rupture, etc. There are certain instances where it could be embolus, atrial fibrillation patient having an embolic episode and an embolic occlusion of the coronary artery. You could have a patient who can have a coronary erosion. You could have a patient with a spontaneous coronary dissection. Now, these conditions you may not be able to decide with angiography alone. And I think that's when IVUS and OCT becomes useful. So in these conditions, IVUS and OCT are useful for diagnostic purposes. And also these conditions are useful after stent implantation to make sure that the stent is correctly positioned, the stent is expanded properly, that calcified nodules are taken care of, there's no proximal or distal dissection. So I think there's benefit, of course, at a cost in terms of financial cost for doing these procedures. Then the algorithm of patients who come to you with cardiogenic shock. So there are patients who come with cardiogenic shock, the left hand out here. In patients who come with cardiogenic shock, you must do immediate PCI and you must do PCI only of the infarct-related artery. And then you can do complete revascularization as a second procedure. In patients who come with STEMI, you can do complete revascularization at the same time, or you can do the second non-culprit vessel before discharge or within a few weeks of that. And if patient has a non-STEMI, you can do complete revascularization at the same time, and you can use FFR or the other non-invasive methods to see whether the other plaques require to be done or not. The question of whether everything should be revascularized at the same time or at a later date is full of debates and full of multiple trials, some in favor, some against. But I think, in my opinion, the best situation would be to do the immediate culprit-related vessel immediately, stabilize the patient, and then do the other vessel before the patient goes home. So the patient doesn't have to get readmitted for the second procedure, and also the patient doesn't have the chance of getting a reinfarction while waiting for the second procedure. But doing everything at the same time is possible. It has benefits in certain situations, but again, it has its own risks and problems. Again, there are patients, as you know, who have got no obstructive coronary artery disease and still have a myocardial infarction. As you know, there is type 1, type 2 myocardial infarction where other reasons are possible. Then, of course, there are a lot of causes that I mentioned earlier: embolism, microvascular dysfunction, coronary spasm, thrombosis, bridging, plaque erosion or rupture. And then there are traumatic causes and non-cardiac causes like sepsis, etc. So you can have an infarction with normal coronary arteries, and that's of course known as MINOCA, minimally invasive, minimal coronary uh, artery disease with normal coronary arteries. So please remember that this is an important aspect. Again, you have to look at the clinical history, physical examination of the patient, and then of course they will require uh, various investigations, including angiography, etc. But it's usually very difficult. It's easy to say this patient has a small vessel disease because there's no real uh, method to diagnose small vessel disease. So this is a method of exclusion. So patients with normal coronary arteries, myocardial infarction need to be looked at differently. And then when you treat the patients, of course, you have to look at long-term management of these patients also. They require long-term support and management of risk factors as well. So the ESC concentrates a lot about long-term management as well. It's important to remember that when a myocardial infarction has taken place, the non-culprit vessel is often more responsible for the second myocardial infarction. So first of all, when you have an infarct, you have a much greater chance of reinfarction in the first 1 year, and the chances are more from the non-culprit vessel rather than from the culprit vessel. So you have to look at these non-culprit, non-critical lesions because they rupture. And one of the best ways to treat these patients is by good intensive lipid lowering therapy. I don't need to go into these details, but I've just mentioned three things: that in patients with acute ACS and patients with high risk coronary artery disease, ACS recommends, ACC recommends guidelines of LDL below 55, ESC recommends LDL below 45, and the Lipid Association of India recommends LDL below 35. So clearly the LDLs of 60, 70, which we often see in our patients, is not advisable. Try and bring the LDLs to below 50, 45. I think that will be significantly beneficial. And you can see out here, again, don't want to go into details, but again, class 1, class 1, class 1 in terms of LDL reduction, bring it down to below 45, and you can use a combination of statins with ezetimibe. And I'm going to talk a little bit about PCSK9 as well. The reason why I'm going to talk about that is that you get an LDL modification during acute myocardial infarction. So when you have an SCS, the LDL synthesis is increased, so more LDL is produced. Number two, LDL has a predisposition for oxidation, so more oxidized LDL is produced. LDL particle is smaller in patients with ACS, and we know that small, dense LDL is very atherogenic. And the first 2-3 months after ACS, the LDL should be kept low because not only because the LDL goes up, but because you get a bad LDL as compared to the normal situation. The second thing that happens in ACS is that the PCSK9 levels rise. So there's actual rise of PCSK9, and PCSK9 is very harmful. PCSK9 increases coronary plaque vulnerability. It has pro-inflammatory effects. It has effects on the LDL oxidation. It changes the plaque composition and makes it more likely to rupture and thrombose. So inhibiting PCSK9 is very important. You can see a number of trials. There's a trial here which shows the non-ST segment elevation, PCSK9 rises and is associated with hypercoagulability and hyperinflation. And therefore, we need PCSK9 inhibition. By inhibiting PCSK9, you get all these benefits. So not just in terms of reduction of LDL, but in terms of reduction of inflammation, reduction in the type of LDL, which is small molecular LDL, effect even on platelet aggregation and activation. There are a number of trials looking at PCSK9 in acute myocardial infarction. This is the IVAX trial, and you can see you get a very significant within hours reduction of LDL cholesterol. There's another trial here which again looks at the sham versus aliricomab, and you can see significant reductions of LDL to values below 30, which are very important in this situation of acute MI. Now, also we know that PCSK9 can inhibit the small dense LDL, and as I mentioned to you, the small dense LDL, which is more atherogenic, increases after myocardial infarction. Therefore, it's even more important to combine PCSK9 inhibitors along with statins in acute myocardial infarction. There are a number of trials here, for example, PCSK9 given in hospital with myocardial infarction. There's a reduction of rehospitalization, reduction of myocardial infarction. Another trial showing prognosis improved at 3 months following patients with acute myocardial infarction. And again, a trial looking at the pro-inflammatory cytokines, which can be inhibited by PCSK9. As you can see from a number of these trials, that the reduction of inflammatory responses is also a very important component of treatment of post-ACS recurrence of myocardial infarction. So number one, reduce your LDL to as low as possible, preferably below 45, and also look at PCSK9, which will help to do that, and also the anti-inflammatory properties of PCSK9, which are also important. And as you can see here, by giving PCSK9, you get a 60% reduction of LDL. You get some reduction of triglycerides as well. But again, you can see all these inflammatory markers are significantly reduced with PCSK9. If you're using anti-inflammatory, is there any other drug that you can use? As we all know, colchicine has been tried very often. There have been earlier trials called the Lodoco trial, the Loclot trial, and these drugs have also shown that using colchicine in a small dose of zero point 0.5 milligrams can have benefit in terms of future events. However, again, there has been a debate because a new trial came out called the Extrom trial very recently presented in ACC, which showed that they did not get any significant cardiovascular events. But what they found is that it reduces the progression of the coronary plaques. So clearly, the use of anti-inflammatory properties of PCSK9 and a direct anti-inflammatory agent, like colchicine in 0.5 milligrams daily to reduce plaque progression and to have benefits in terms of cardiovascular events. So I think you need to attack ACS patients all told. The antiplatelets is one part of it, the lipid lowering is one part of it, and the anti-inflammatory is the third part of it. Again, this has not been discussed in most of the trials. We use a lot of trimetazidine in patients with chronic coronary syndrome. So both ESC and ESC advises trimetazidine in coronary syndromes, but in acute coronary syndromes, also trimetazidine is useful. It has these multiple effects in terms of reactive oxygen apoptosis, etc. And what trimetazidine does is reduces reperfusion injuries. When you have a myocardial infarction and there's total occlusion of the coronary arteries, when you reperfuse the artery by putting a stent and doing angioplasty, you actually get reperfusion injury, which often produces arrhythmias and various other problems. And if trimetazidine is given along with at the time of your angioplasty or before the angioplasty through these multiple mechanisms that's seen out here, it prevents reperfusion injuries. Similarly, nicorandil, if given intracoronary before you do the reperfusion, that means before you do the angioplasty, it reduces reperfusion injuries. Two drugs which are not often spoken about, trimetazidine and nicorandil, are according to me important drugs to prevent reperfusion injury and prevent further damage to the myocardium during the process of angioplasty. There are multiple trials on trimetazidine. It's actually an Indian trial which shows that the use of trimetazidine before myocardial infarction can produce significant reduction of troponin release. So as I mentioned, release of troponin means myocardial necrosis. If you give trimetazidine before procedures, troponin values are reduced, suggesting less myocardial necrosis. There's also a more recent study in American College of Cardiology. All patients were given atorvastatin high dose, and one group was given trimetazidine, and the one given trimetazidine has significant benefits in terms of reduction of NT-proBNP, other cardiac biomarkers, and in fact a reduction in major cardiac events as well from 14 to 6.5% in the combination group. So again, nicorandil, trimetazidine important, and these are important to give before your procedure. So before you do the angioplasty, they need to be given, because then what it does is it reduces this reperfusion injury, which contributes significantly to the damage in the myocardium. There's also a more recent Patmos trial, which looked at the fact that trimetazidine can reduce microvascular dysfunction. And we all know that once you open the coronary artery, do an angioplasty, still about 30-40% of the patients get angina. And that is presumed to be because of microvascular damage. The microvascular endothelial gets damaged, all these thrombi, etc., which go down during an infarction and during the procedure, produces occlusion of the microvascular system. And it's important to look at microvascular dysfunction as well. So microvascular dysfunction you treat by reducing lipids, by using anti-inflammatory drugs, by using trametazidine, nicorandil, etc. So you treat the major coronary arteries, and you also treat the microvasculature, is also a very important part of treatment. Now, we all know that empagliflozin and various SGLT2 inhibitors are very useful in treatment of heart failure. Are they useful in treatment of acute myocardial infarction? It's a very specific trial giving empagliflozin to patients with acute myocardial infarction to see whether it had benefits. And what they found in conclusion was that patients had increased risk of heart failure after infarction. That means those who had more myocardial damage, more low ejection fraction, empagliflozin significantly reduced the first hospitalization from heart failure or death compared to placebo. So it didn't produce any dramatic benefits in terms of reduction of infarction, etc. But in those who already had an infarct and a poor ejection fraction, starting early SGLT2 inhibitors may reduce the chance of future heart failure, etc. So I mentioned about lipid lowering drugs already. All patients are usually given beta blockers. So beta blockers are class 1A recommendation. Beta blockers are particularly important when the ejection fraction is low because we know that beta blockers are useful for heart failure patients. How long you should continue beta blockers is a lot of debate going on at the moment. Clearly, patients who have got angioplasty done and whose LV function is normal need not be given beta blockers indefinitely. But in those patients who got PCI but who have low ejection fractions, beta blockers need to be given for the low ejection fraction. And then, of course, you need to give RAS blockers. And RAS blockers, AC inhibitors, usually are better in myocardial infarction than ARBs. And again, class 1A indication, clearly they benefit patients. And again, lower the ejection fraction, greater the benefit. Same thing with mineralocorticoid antagonists. You can give them during acute infarction and certainly in those patients who have reduced ejection fraction. At one stage, they were suggesting giving spironolactone to all patients with acute myocardial infarction, but then another trial came in which said it wasn't so beneficial. But clearly, in those with low ejection fraction, it is considerably beneficial. Then, of course, we mentioned about polypill as a continuation of long-term multiple therapies in patients after treatment for ACS. Cardiac imaging is important, mainly echocardiography to see for LV function, to decide about whether patient needs an ICD implantation, alter monitoring of certain patients. Magnetic cardiac imaging is important to see whether the patient has got a hibernating heart or a completely damaged heart. Is the heart scarred off? Will they benefit from future procedures or not? That's all important. And then, of course, cardiac rehabilitation is extremely important, class 1A indication. So all patients who had an ACS, who undergone procedures, either thrombolysis or PCI or only medical therapy, they all need cardiac rehabilitation. And again, lifestyle management, stop smoking, reduce alcohol, healthy diet, regular exercise. All this is so very important and should be continued in patients with ACS. An important point to remember, the difference between male and female presentations. Now, both of them will have chest pain, the male and female. Both of them may have diaphoresis, arm pain, shoulder pain. But what women have more frequently is they often come to you only with dizziness, only with nausea, vomiting, more jaw pain rather than chest pain, and shortness of breath. So sometimes women are mistaken as not having ACS, particularly if the ECG is not diagnostic when they come with these manifestations rather than chest pain. So please remember, women often present with atypical manifestations, and please keep that in mind when treating these patients. Now, of course, we have talked about the use of antiplatelet agents immediately after plasty, the use of stopping aspirin after 3 or 6 months, but we need also long-term therapy. So patients who have undergone an ACS and whether or not they've undergone a plasty, but especially those who undergone a plasty will require long-term antiplatelet therapy. Usually, it's not necessary to give two antiplatelet drugs forever because that increases your bleeding chance. So you can give either aspirin or clopidogrel lifelong. The host exam trial looked at the difference between aspirin versus clopidogrel, and surprisingly, it was found that clopidogrel had the same benefits as aspirin but less bleeding. Now, in the past, we all used to continue aspirin and stop the clopidogrel when we wanted to stop dual antiplatelet therapy. But the recent paradigm has changed. We continue to use clopidogrel and stop aspirin in most of these patients. Also, the other option is to use 60 milligrams of ticagrelor instead of 90 milligrams. Usual dose is 90 milligrams twice a day when you do the plasty. And then after a year, you continue to reduce to 60 milligrams. And you can see that for 60 milligrams, the primary efficacy of stroke, myocardial infarction remains the same as 90 milligrams, but the bleeding is less. Now, again, ACS very much concentrates on person-centric treatment. That means you have to look at the patient in totality. You have to look at the pre-morbid conditions of the patient. You have to treat the patient during the hospital stay and then prepare the patient at the time of discharge, not just in terms of medicine, but also mental and emotional health. As you know, many of these patients after an infarction get into depression, get into all sorts of other problems, and that needs to be tackled as well. So, so you have to give an information to the patient, heart health. How can I improve my heart health after myocardial infarction? So don't smoke, eat healthy, avoid alcohol, exercise regularly, see your doctor regularly, take your medicines regularly. Big problem. Adherence to medicine is a big problem, and this needs to be explained to the patient again and again. The best way to improve adherence is communication. Various methods are available. Then, of course, take your flu vaccine, because these patients with infarction, especially those with low ejection fraction, if they get flu, they may get into pneumonia and various other problems. And then, of course, keep a close check on your weight, on your cholesterol, on your blood pressure, and your sugar. So keep a close check on your values and manage your stress. So meditation, yoga, another very important thing which is now becoming very popular in the West as well. Meditation is becoming an important part of treatment of healthy heart in patients who had an ACS. And then, of course, I would end by saying that in everything in medicine, you should have a teach back technique. What happens is you sit with the patient and explain to them everything, and you feel that the patient is understood, but clearly the patient has not understood half the things you said. And therefore, you should ask the patient to explain back the concept to you. So if you have spoken to them about, say, whatever it is, meditation and heart failure, or taking your antiplatelet therapy, or keeping your LDL low. Let's see a simple thing as keep your LDL low, you give them treatment, you explain to them, patient goes home, takes medicines for 3 months, and then cuts down the dose or stops the drug. So in order to prevent that, you have to ask the patient to explain the concept. You'll be surprised. Half the time, half the patients won't know what you've spoken about. And then you have to review the points missed out and accept and then ask the patient again. So it's like a teach back phenomena to improve compliance of the patient, to improve the doctor-patient relationship. And I think as important it is to do a fantastic angioplasty job, I think this is also very important from long-term management of these patients, because most of the patients today survive myocardial infarction because of all the specialty available, but the long-term problems remain, and I think we need to take care of that. So thank you very much indeed for your time.
So much, sir, for that wonderful topic. We do have a lot of doubts coming in from our doctors, and we will be getting into that. So, taking one of the earlier questions we had and highlighting it on the screen for you, sir. So, Dr. Kaushal asked, we consider ticagrelor as DOC as far as diabetes are concerned. So, what are the advantages of using ticagrelor over more commonly available alternatives like clopidogrel? Also, would it make a big difference in overcrowded and low resource setup?
I'm sorry, I sort of missed that bit because I couldn't get. Sorry, I'll just read the question. We
Yeah.
consider tricolor as yes. The question is whether you should use clopidogrel, ticagrelor, or prasugrel. Yes, ticagrelor is more expensive, so as you mentioned, in low resource setup, it may be preferable to use a cheaper drug compared to a more expensive drug. However, the trials have shown that ticagrelor is more effective in terms of reducing cardiovascular events. Uh, And I've certainly seen it in my practice that with ticagrelor, the incidence of stent thrombosis is significantly less. Clopidogrel has the disadvantage in that there's a lot of patients, about almost 30% of patients who have clopidogrel resistance. Now, clopidogrel resistance does not necessarily always mean that the patient has got clinical resistance. So we are doing clopidogrel resistance in vitro, and we don't know that it always manifests as vein thrombosis, etc. But we do know that there is no tachycaloric resistance. So that is one aspect of the problem that you must remember. You should also remember that there is also something called aspirin resistance, which is almost as high as clopidogrel resistance. So if you have a patient who's got aspirin resistance and clopidogrel resistance, and he'll have a much significant chance of getting a stent thrombosis compared to somebody who's on aspirin and ticagrelor, because at least then he'll be protected by one. Of course, the clopidogrel still remains the most common antiplatelet drug along with aspirin all over the world. So clearly, I'm not saying clopidogrel should not be used. Also, we know that ticagrelor has got more problems with bleeding because of a more powerful antiplatelet drug. When you're using a NOAC, it is much better to use clopidogrel and a NOAC rather than ticagrelor and NOAC to reduce the chances of bleeding. So there are advantages and disadvantages. And again, clopidogrel has come out better when you have to choose between aspirin and clopidogrel for long-term therapy. That was a bit of a surprise because almost all of us for all these years, when we had to stop the dual antiplatelet therapy, would stop clopidogrel and continue aspirin. But a couple of trials have now come out which suggest that clopidogrel, in fact, is as effective or if not more effective and surprisingly produces less bleeding because a large amount of bleeding with aspirin is GI bleeding, which significantly reduces with the use of clopidogrel. So I think that's where we stand today. Of course, prasugrel is cheaper, and you can use prasugrel instead of ticagrelor. And there are a number of trials to suggest that prasugrel is also a very good drug, and that's something also that you could look into.
So, highlighting the next question, Dr. Kulkarni asks if you could enlighten about the pathophysiology of cardiac tamponade.
Of course, cardiac tamponade can occur because of multiple reasons, an acute pericarditis or a bleed in the pericardium, malignancy, etc. And of course, what happens in cardiac tamponade is that the heart cannot dilate, so it cannot fill, your blood pressure tends to fall, pulmonary circulation tends to get impeded. And if the cardiac tamponade is acute, then the patient goes into shock much more easily than if the cardiac tamponade is slow. So if you've got tuberculosis, for example, and gradually filling up of the pericardium, then the pericardium and the heart accommodates to that, and the patient will be much more stable. If you have an acute tamponade, even though the volume of fluid in the pericardium is much less compared to a chronic tamponade, the patient can be in a much greater distress and shock. And of course, the only way to treat cardiac tamponade is to drain the tamponade. Now, the classic example of acute tamponade is when we are doing an angiography or angioplasty particularly, and we get a perforation of the coronary artery and blood starts pouring into the tamponade. You are actually watching the patient, and within minutes, the patient goes into shock. And that's because there's an acute bleed into the pericardiac sac, and the patient goes into an acute cardiac tamponade because the blood coming into the myocardium is restricted and cannot. And when these patients are almost dying in shock, you simply put a needle in the pericardium and drain out the fluid. Even if you drain out 50 cc's of fluid, the patient's condition improves dramatically. That's a very classic example we see in the cath lab of acute pericardial tamponade occurring with coronary perforations.
So, next question by Dr. Ramesh. Sir, is it possible to have cases with single coronary artery who would survive after thrombolysis?
Oh, yes. Thrombolysis actually is a very good treatment. It is sort of not as dramatic as angioplasty. Of course, it came before angioplasty, and thrombolysis has been very useful. Now, earlier we used to use streptokinase, which had its own problems. It had to be given by an infusion. It often produced allergic reaction. It often produced hypotension. But now, with the availability of tenecteplase, the thrombolytic therapy has completely changed. It's a single bolus dose that's given. It doesn't produce hypotension or allergic reactions and is very effective. So giving thrombolysis to a patient is a very good form of treatment. In fact, if within the first 60 minutes, thrombolysis is as effective as angioplasty. Now, the problem with thrombolysis is that it removes the clot and therefore allows the circulation to happen, but the underlying problem is not relieved. And therefore, it is important that we do angiography on all patients who have been thrombolized. Now, many of these thrombolized patients may not need angioplasty because you have a plaque rupture or a coronary erosion with thrombus, and the thrombus is dissolved and the underlying lesion may not be significant. So, in fact, after thrombolysis, a significant number of patients do not need angioplasty. But there are still a significantly group of patients who will have an underlying severe stenosis who will require an angioplasty and stenting after thrombolysis. Pharmacoinvasive therapy, that means thrombolysis early, followed by angiography and SOS angioplasty, is now considered as a very, very important part of treatment of ACS. So, when you have a myocardial infarction, you have a patient who's got a myocardial infarction, STs are elevated. You must make an immediate decision as a medical person as to whether you can do a PCI within the next 60 to 90 minutes or not. If you can, and please believe me, it is very difficult. Even patients in the hospital, even when they come to the emergency, cannot necessarily have an angioplasty done within 60 to 90 minutes. The cath lab may be busy, procedures may be going on. Most hospitals have a single cath lab. Somebody may be doing a pacemaker, somebody may be doing another angioplasty. It may take 2 hours. Some patients come at night. The doctor may not be available. More important, the technicians often stay far away, especially in Bombay. Most, as you know, technicians stay far away. They take an hour to reach the hospital. So, similarly, in such a situation, even in the hospital, it takes sometimes an hour to do an angiography, angioplasty. When a patient is already an hour or so away, then you can better to thrombolize the patient because thrombolysis is much easier. Any small town hospital with a little ICU can give thrombolytic therapy. So just push in tenecteplase and the patient will have significant benefit. And then, of course, you can transfer the patient. So I think thrombolysis has a very important role to play. But after thrombolysis, patients must have an angiography done. And then only you should decide whether angioplasty is required or not required.
So next, Dr. Rao was asking, while giving soluble aspirin, how can we be sure that the patient does not have peptic ulcer?
Well, the one condition I should have mentioned that the one time when you should not take aspirin is maybe the pain which you are having is because of a peptic ulcer bleed or a rupture or something like that. Yes, then of course, if you got esophageal rupture or a peptic or a ulcer rupture and then you get chest pain and you take aspirin, you may make conditions worse. But besides just excluding that particular point, aspirin will help the patient. A patient with a chronic ulcer is not going to get dramatically problematic with one aspirin compared to somebody who's having an infarction and who doesn't get treatment for that. Soluble aspirin, of course, because it can act quickly. So what we say is keep soluble aspirin in your pocket. I tell everybody to carry one soluble aspirin in their pocket. And when you feel that you have a chest pain, that means you should have some knowledge about what is cardiac pain. So if the pain is in the center of your chest, shoulders, jaw pain is not settling over the next 10, 15 minutes, and you're breathless, most people will know that this is an unusual sort of pain. You simply put this aspirin under your tongue and just chew it and then swallow it. So if you chew it, then the effect becomes even faster. Many of these drugs, we ask them to chew. As you know, there are a number of trials on chewing ticagrelor and chewing prasugrel as well. There are a couple of trials which show that if you chew ticagrelor, the action is faster. So if you're taking a patient for immediate plastic ticagrelor, if you swallow, it may take time, and therefore you chew it, and the effect is better because some amount of absorption is through the mucous membrane. And also sometimes when you swallow tablets, especially in patients who are hypotensive, etc., there's gastric delay, and many of these tablets remain in the stomach and not get absorbed, etc. So there are issues with oral tablets as well. That's why intravenous cangrelor would probably be the best because you give it intravenously and it acts immediately. Again, cost is an issue, but cangrelor is available in our country as well. So yes, enteric-coated aspirin will take longer time, so you preferably use soluble aspirin. But so these are the plus minuses. But overall, taken all together, chest pain, unless you're the unfortunate patient with a ruptured peptic ulcer or something, aspirin will benefit.
Next, Dr. Shri asks, sir, any comments on management of ACS and vasculitis patient?
ACS or other coronary problems in vasculitis is a different ballgame altogether because then you have to treat vasculitis and the inflammatory issues of vasculitis, etc. So clearly, we are not talking about coronary artery disease and various vasculitis or various vascular other formations where more often you get dilatations of the coronary, ectasia of coronary artery aneurysms, as you know. So this is a totally different aspect of treatment and totally different treatment as well. But when you talk of small vessel disease, that's again a different concept. Many people have angina with normal coronary arteries, angina in spite of angioplasty. And this is small vessel disease, very difficult to diagnose small vessel disease. You can do various tests to see flows and things like that, but that's not commonly done. As I mentioned, two drugs particularly useful for microvascular disease are trimetazidine and nicorandil. Ranolazine also is sometimes beneficial in small vessel disease. And then, of course, you have coronary spasm, which can be a cause of acute myocardial infarction or at least angina. In such a situation, you get marked ST elevations. There's a coronary artery spasm, and once you relieve the spasm, best drug for that would be nicorandil. And then the ST segments settle, the pain settles down. So coronary artery spasms can be provoked by giving intravenous or intracoronary ergonovine. And we have done a lot of tests in the past doing this thing. But now, of course, not many people do the ergonovine test.
Next, Dr. Kaushal asks, do we have any marker or clinical sign which can predict future risks of ACS in geriatric group patients?
Well, one of the ways in which you can future predict development of coronary artery disease is troponin. So troponin, besides being useful in the diagnosing of acute myocardial infarction, in a chronic, normal, stable patient, those who have high troponin values, they have more chances of future coronary artery or vascular disease. And there are a number of trials on that. And we did a study also at Kokilabin in health checkup patients looking at troponin values. And there are a number of data on that, that higher the troponin value in a normal patient, so-called normal as we say, is associated with future increased cardiovascular events.
Next, Dr. Singh is asking for how long should the dual therapy be continued?
Dual antiplatelet therapy usually stopped at the end of uh, uh, let's go back to history. In the past, when you used to use aspirin and ticagrelor or aspirin and clopidogrel, we used to stop dual antiplatelet therapy at the end of 1 year and then put them on a single antiplatelet therapy unless they were a very high risk group of patients. So if I had a patient who was a diabetic, who had a strong family history of heart disease, and who had a complex angioplasty, preferably something like a left main bifurcation plus multiple stents, long stents, then I think you'd continue dual antitherapy for a very long time. Otherwise, in most patients, we used to stop. And in the past, we used to stop aspirin. Now we used to stop clopidogrel, continue aspirin. Now we stop aspirin, continue clopidogrel. Now, recent data has suggested, and I showed you a couple of trials, that in stable patients, you can stop dual antiplatelet therapy after 1 month. And in post-ACS PCI patients, you can start dual antitherapy after 3 months and continue only ticagrelor. You cannot continue only aspirin. Can you continue only clopidogrel? Yes, some studies have. I'm a little apprehensive of continuing only clopidogrel, but at ticagrelor, I'm quite happy. Stop aspirin, continue ticagrelor after 3 months. The question is, what do you do at the end of 1 year? I don't like to continue ticagrelor indefinitely. So at the end of 1 year, if a patient's on ticagrelor 90 milligrams twice a day, you have two options. One is you can reduce it down to 60 milligrams twice a day. But again, how long do you continue that? You can't continue it lifelong. So maybe another couple of years, as the trial had shown. Or at the end of 1 year, you can shift them over to clopidogrel and then continue clopidogrel single antiplatelet lifelong. So it's a little complex what you should do at the end of 1 year, but this is how I think is the best way to manage. But again, you have to look at the patient. Normal patient, single stent, normal function, non-diabetic, clearly you should stop and give only one antiplatelet drug. Complex patients with complex spasticity, high-risk patients, diabetic patients, you may want to continue dual antiplatelet. And again, dual antiplatelet, aspirin and ticagrelor long-term will have more bleeding. Aspirin and clopidogrel will have lesser bleeding. So again, you have to decide what to do. Therefore, individualization of treatment is most important. As I mentioned, age, past bleeding, anemia, and CKD. Be careful of those patients. They are the ones who have more bleeding.
So, next question by Dr. Humaira. Many patients complain of shortness of breath after starting ticagrelor, and how do we tackle this?
Many doctors say that they've seen a lot of patients. I must admit, I have not seen a lot of patients. Yes, I've seen a few patients. I remember one patient very vividly who almost told me that after starting ticagrelor, he felt he was going to choke to death at night. He was so breathless at night, and stopping the ticagrelor immediately removed that. People are not that symptomatic. Usually, they do complain of breathlessness. It becomes a little difficult if the patient's got a poor ejection fraction and you're not sure whether that is because of LVF or because of ticagrelor. Most of the times, if I feel that ticagrelor is important for the patient, I reassure the patient. I tell them that it is because of the drug and it will settle down. And often it does settle down. But in some patients who do not tolerate it and who continuously complain of breathlessness, I would stop it and shift them over to prasugrel or clopidogrel. But it's not a common problem, according to me. It's not a sort of a problem which doesn't go away after stopping ticagrelor. It just goes away after stopping ticagrelor. So if it troubles you, stop it. Try and reassure the patient. Most of the times they will settle down. Very few patients will not settle down, in which case you shift to prasugrel or clopidogrel.
So next, Dr. Kaushal is asking, in case of INOCA and MINOCA, where we cannot perform PCI, are there any interventions available other than treating medically?
There's really no need to do anything PCI wise. There's no need to do any intervention because the arteries are normal. Now, why do they get angina? That's a more difficult question. You can say it's spasm, in which case you can try nicorandil. You can say that it is small vessel disease, in which case you could try again nicorandil. You could try and use dimetazine, as I mentioned. Again, there are some sort of intravascular studies that you can do to look at the peripheral coronary flows, etc. Not commonly practiced. So you'll have to just treat it as somebody who gets angina-like symptoms or who has angina or positive stress test or a positive nucleus test suggesting that they do have genuine ischemia, but you do an angiography or a CT angio and the coronary arteries are completely normal. In which case, I think the only thing is to treat them medically. Also, very important to look at the risk factors. So try and stop their smoking, try and treat their lipids, uh, try and make them exercise, try and reduce their stress levels. All these things would benefit. Stop smoking. All these things would benefit. But other than that, there's really nothing very much more you can do.
Next by Dr. Shri Jyoti, can we use ARNI in HFrEF 30% if BP is 80 by 60 mm of HG?
That's the most difficult part of treating heart failure patients is when heart failure patients have got rising creatinine, rising potassium, or low blood pressure. Now, why is the blood pressure low? Is the blood pressure low because you're giving too much diuretics? So one of the first things to do is, first of all, make sure that the patient is not on any other drug. Sometimes patients are on other drugs which can produce fall in blood pressure. So try and make sure there's no other drug is there. Secondly, patient may be on too many diuretics and maybe a little hypovolemic. So cut down the diuretics in these patients when you are giving ARNI. Then you can always give ARNI in very small doses, like even 25 milligrams once a day to start off with. As the heart function little bit improves, the blood pressure will also improve. If a patient is asymptomatic and blood pressure on standing is 80 by 60, patient is asymptomatic, I would still use ARNI in a small dose and see how they tolerate. But clearly, there are some patients who will not tolerate even the smallest dose of ARNI. The blood pressure drops, particularly on standing. They're very symptomatic when standing, feel giddy and almost fall down, in which case you cannot use ARNI and you will have to use some of the other drugs. You should also make sure that they're not on too much beta blockers or not too much on other drugs, and you can reduce down all the drugs. So Vericiguat is a good option for these patients that doesn't produce that much fall in blood pressure. It doesn't affect creatinine or potassium and can help to improve the ejection fraction. And once the ejection fraction improves a little bit, blood pressure improves a bit, you can start ARNI on these patients. But it's a difficult situation. Creatinine, potassium, low blood pressure, and the use of ARNI. Difficult.
So we still have some questions. Is it okay if we take a few more?
Sure.
So next is by Dr. Agarwal. Sir is asking, if you get an acute MI patient in a health unit, perhaps PHC, and PCI facility is far away, can you give thrombolizing agent? And if so, which one and what dosage would it be?
I mean, absolutely must. In fact, if you can't do PCI to the patient, you must thrombolize the patient. The only reason why you would not thrombolize a patient if he's had a recent stroke or cerebral hemorrhage or a recent GI bleeding or a significant hemorrhage, that would be a problem. For a patient who's had recent surgery, say some spine surgery or some other complicated surgery, and then the patient has an infarct, that's really very difficult to treat because you don't want to give thrombolytic agent. Otherwise, you give tenecteplase, dose adjusted tenecteplase, which would be the best thing to give. It's a single bolus injection. Many people use retiplase, but my preference is tenecteplase, and I think that's the most common drug use. I think people sometimes use streptokinase because it's cheaper. I'm not sure really the cost difference is that much to use streptokinase and not tenecteplase. However, streptokinase is also better than no thrombolysis. So if you have no facility for PCI, you don't have tenecteplase or retiplase, but you have streptokinase, please use streptokinase. Streptokinase will also produce a significant benefit to the patient. You need to monitor them a little bit closer and you need to wait a little bit longer after you give streptokinase before you can do angiographies But clearly, any thrombolytic therapy is better than no thrombolytic therapy unless there is an immediate contraindication for that.
Next, Dr. Josephine is saying patient with recurrent MI is already on dual antiplatelet beta blockers. After PCI after 1 year, should we increase the dose of dual antiplatelets or do we redo the PCI?
If a patient who's already on dual antiplatelet therapy and has infarction, I mean, that's not uncommon at all. I mean, any patient who has an infarct once can have an infarct again. In fact, the second chances are more high. And if you get an infarct again, you treat him just the same way as you would with the patient who's had a first ACS. So, a patient will require thrombolysis if required. Again, you have to be careful now. The patient's already on dual antiplatelet therapy and you thrombolize the patient, then the bleeding chances are more. So preferably these patients should go for an early angiography rather than early thrombolysis. So you do an angiography and you see what the problem is. The problem may be stent occlusion, in which case you redo whatever has to be done for the stent, or the stent may be fine and there be another artery occlusion, which you treat it as any other ACS with another stent. So clearly it depends on what the situation is like, but not an uncommon problem. Patient with a PCI and a reinfarction, maybe a 6 months later, 1 year later, 2 years later, not an uncommon problem at all. And the only way to prevent that is to do aggressive medical treatment after the first plasty. By aggressive medical treatment, not just the dual antiplatelets, but the lifestyle modification, stop the smoking, exercise, meditation, weight loss, and very good antiplatelet therapy. I keep concentrating on very good anti-lipid therapy. I keep considering the best way to prevent future cardiovascular events is to keep your LDL as low as possible. Lots of data are there to keep LDL down. We know, for example, for intracoronary IVUS and intracoronary uh, OCT studies, that if you keep your LDL low around 20 or 30, you get plaque regression. The total plaque burden reduces. The fibrous cap becomes thick and less likely to rupture. Patients which have got vulnerable plaques get calcified. So keeping LDL low is the best way to prevent future further cardiac events in somebody who's already had an ACS. So concentrate on lipid reduction, please. People don't think about it. People put them on statins and reduce the dose down. No. All patients who come with ACS, in my opinion, should be on statin full dose plus ezetimibe because that contributes a bit further. And a lot of data to suggest that they should also be on ACS at the time of the should be on PCSK9 inhibitor at the time of ACS, and then you can stop it after 6 months or depending on what the lipid is like. As you know, Repatha is available, and as you know, inclisiran is available. Inclisiran you have to give once in 6 months, but its action is slow. So therefore, it's preferable to give Repatha during the ACS and then use inclisiran maybe later on. Inclisiran, if given during ACS, takes a little longer time to act, and you want very quick action. The best thing to do is to give Repatha at the time of your angioplasty, give every 15 days, maybe for 2-3 months at least. That will reduce the anti-inflammatory problems. That will bring the LDL down dramatically. Then at the end of 2-3 months, you can decide what to do. Cost is there, of course, but then cost of angioplasty is high. Few months of anti-lipid therapy with Repatha is not going to add dramatically to the cost of a complex angioplasty.
Next, Dr. Mittal is asking after how many hours or days one can go for angioplasty after thrombolysis and acute MI?
Well, if you thrombolize with streptokinase longer time, if you thrombolize with tenecteplase, you can take them up within the next few hours, maybe 6 hours or so, because by that time most of the effect will wear off. There is no urgency to do an angiography if the patient is not symptomatic. So if you're given thrombolysis, your ST segments have settled down, the patient is chest free, you have sufficient time. You can wait till next day morning, do it as a planned procedure rather than in the middle of the night, etc. However, if during that waiting period the patient gets chest pain again, or the ST segment begins to get up, immediate angiography and angioplasty will be required. But otherwise, usually do it within the next 24 hours.
So, Dr. Arora says in cases of long COVID, the event of SCD taking place, 4 cases autopsy I attended. In all cases, coronary vasa vasorum were blocked with inflammatory big plaque, virtually blocked the coronary arteries totally. So, how do we diagnose and treat before SCD?
Of course, COVID is a different problem altogether, and the inflammatory problems that are associated with COVID are very different. But I think inflammation as a part of atherosclerosis and inflammation as a part of treatment of atherosclerosis and acute coronary artery disease, as I already mentioned, is being looked into. So, how do you reduce the inflammation in these patients with acute coronary syndromes? One, as I mentioned, with PCSK9 inhibitors, which have anti-inflammatory properties. We also know that statins also have some anti-inflammatory properties. So, high dose statins will also be beneficial. And then, of course, you have other drugs like colchicine, etc. A lot of talk has been done about anti-inflammatory, but nothing really has come about a specific anti-inflammatory drug. Colchicine came out well in the earlier trial, showed significant benefit in terms of cardiac reduction. Then the latest trial, which came out this time in ACC, did not show any benefit. So there was a little bit of doubt. Then they came out and said that it didn't show benefit, but atherosclerosis was reduced in the coronary artery. So a little bit of hodgepodge treatment with colchicine. But again, I see no harm in these patients who got high inflammatory burden like post-COVID, etc., to use colchicine along with statins or other anti-inflammatory drugs. We don't have any great new anti-inflammatory drugs which are in the available as a routine.
So, doctors, in the interest of time, I think we can take around two or three more questions. Um, so, next is by Dr. Madhav. Is coronary spasm more common in small vessel disease?
Difficult to answer that question. Nobody knows. We've seen coronary artery spasm in large vessels, very difficult to know in small vessels. How do you see? You don't see small vessels on angiography. So, how do you diagnose? I remember when I was in UK, like what, 50 years ago, we did a lot of trials on giving intravenous ergonovin. At that time, there was a lot of talk about coronary artery spasm. Some of you who are old may remember Dr. Mazuri, who was from Italy, who then moved to UK. He was a sort of proponent of coronary spasm as a cause of myocardial infarction. So at that time, we did a lot of studies of intracoronary ergonovin to produce coronary spasm. And we could see in some patients there was dramatic coronary spasm. The patient with ST segment elevation, severe chest pain, he thought he'd almost die. And he quickly gave intracoronary nitroglycerin, etc., to relieve the spasm. So coronary spasm is possible. Now, we don't see small vessels easily on angiography. So how do you find out this coronary spasm? You really can't. So you can't diagnose it. You can theoretically say that it may be possible. And again, treatment remains the same, nicorandil, nitroglycerin.
Taking the next question by Dr. Agarwal. Coronary angiography versus CT angiography versus calcium scoring. How do we go about in a suspected case of CAD?
Well, if a patient has an acute syndrome like ACS, for example, then clearly coronary angiography is the gold standard. If a patient comes to the emergency, has chest pain, which is not very significant, you're still worried about coronary artery disease, enzymes are not very diagnostic, you still want to make sure the patient doesn't have to, we often do a CT angiography, especially when the patient is not very keen on an invasive procedure. The CT angio will clear the doubt there's a significant problem or there's nothing, so it helps in such a situation. In a routine situation, calcium scoring is important as a sort of a risk marker for future coronary artery disease. So if you have a 40-year-old guy who wants to know what should I do, then you do a CT calcium score. If it is zero, then the chance of having problems are less. If the patient's calcium score is high, then you don't need to do angiography for these patients. You really need to do better lifestyle modifications, get their sugar better control, BP better control. More important, get their lipids control, put them through regular exercise. So CT calcium score guides you as to how important and how intensive the lifestyle modification should be. On the other hand, the CT angiography has its own advantages and disadvantages. Sometimes you do a CT angio on an asymptomatic guy, find some 60-70% lesion, and he lands up with an angiography and stent, which is absolutely unnecessary. We all know that stenting doesn't prolong life. In fact, doesn't even reduce myocardial infarction. So routine stenting is of no benefit as compared to good medical therapy. We know that from any number of trials. The CT angiography has this disadvantage that you might land up having a stent simply because you found something on a CT angio in an asymptomatic patient undergoing a routine check. However, a CT angiography, according to me, has one benefit. It picks up moderate lesions, and therefore it helps you to intensify the treatment. As long as you don't rush them to angiography and angioplasty, but you improve the treatment in the sense you improve all the factors, all the risk factor modification, intensive statin therapy. And the advantage of that is that when a patient knows on a CT angiography that he's got 40% or a 50% block, it makes him very much aware that now he has a problem. He has seen the problem. We have seen the problem. And therefore, he becomes much more adherent and much more compliant to a treatment than he would be otherwise. And this is particularly so in young people. You see a 50 or 45-year-old man and you treat him and say, no problems, no problems. You do a CT angio and he has 250% lesion, and suddenly he's very happy to take treatment. So it helps you to give adherence and proper therapy. Again, don't rush them for angioplasties and things like that. But coronary angiography is useful for patients who are symptomatic, patients who have definite evidence of ischemia, and who continue to have symptoms and ischemia in spite of proper medical therapy. Of course, coronary angiography is a must for patients with acute coronary syndromes.
So we've had quite some questions on atorvastatin, so I'm taking it together. What is the maintenance dose of atorvastatin and how long do we continue?
My personal feeling is that you should not look at the dose. Number one, what you should look at is the response to the dose. Some patient with a 10 milligram atorvastatin may have an LDL of 30. The 10 milligram is then enough for the patient. Somebody with 80 milligrams of atorvastatin may have an LDL of 90. That's not enough for the patient. Secondly, when you talk of dose, what is the type of patient? Is he a young, asymptomatic patient with no risk factors and no other problem? Then he doesn't require that dramatic a reduction of LDL. On the other hand, you have a high risk or a very high risk patient, that is somebody who's had a procedure done, somebody who's had an infarct, somebody who's also got diabetes. There are many patients who have multiple procedures done. These are the very high risk patients. There, you don't look at the dose of statins, you look at the LDL response. If your LDL is not at the level which you want it to be, say in a very high risk patient, you want an LDL of 35. You give atorvastatin, 80 milligrams, it's not reached the goal. You add ezetimibe, it's not reached the goal. You have to use Repatha or inclisiran. So you have to look at the goal. I feel goal is important, not the dose of the drug which you are using. So clearly, in an acute situation, you give the highest dose along with ezetimibe, and in fact, according to me, along with PCSK9. And in long-term chronic patients, you look at the LDL value depending on the risk factor of the patient. Do not look at the dose, which I think is a mistake many people make. If some patient has 80 milligrams of atorvastatin, somebody or the other will say, "Oh, you're on an 80 milligrams, it's too high dose, reduce to 40, 40 reduce to 20." What has the dose got to do with it? Look at the LDL. The dose is immaterial. So please look at the LDL values as per the patient's risk and then decide what dose to give and whether you should give combinations. According to me, combinations are best. You can use bempedoic acid if the patient doesn't want to take or does not tolerate into statins. If you don't want to use PCSK9, there are a number of trials now using acetamide, ezetimibe, statin, and bempedoic acid triple combination, which is extremely useful and brings reductions of LDL dramatically. So you can combine all the three drugs. You can give one or two, whatever you want. The aim should be to get the LDL to go.
So I think we've covered most of the questions. Just another question is coming before we close the session. Is sorbitrate tablet given?
You can give sorbitrate. I have a little apprehension about giving sorbitrate to patients who never taken it because it often produces hypotension. So many patients who have chest pain, some relative gives them sorbitrate, then the patient faints, and then they say, "Oh God, he's got a heart attack," and rush into the hospital. So I do not advise sorbitrate as a routine. After all, as you know, sorbitrate doesn't reduce myocardial infarction. If you got an infarct to take sorbitrate, it doesn't open the artery, it doesn't reduce the thrombus burden, it doesn't do anything in terms of anything except maybe relieve pain in some of the patients if it's spasm. So sorbitrate for chronic use in patients who are got angina and who get angina and need to take sorbitrate for relief of angina, it's good. Long-term continuous use of nitrates is also not something advised because you get nitrate tolerance, and then when you need it acutely, it doesn't benefit. So I think sorbitrate and acute long short-acting nitrates should be used for acute problems when they're required, not as a sort of a routine. And as I mentioned, in an acute situation where the patient has never taken sorbitrate before and gets a chest pain, there's always a worry that he'll get hypotensive or problematic after that. And as I mentioned, it doesn't reduce the mortality or morbidity of myocardial infarction per se.
So thank you so much for taking so many questions from our doctors very patiently. And thank you once again, sir, for this very enlightening session. I'm very confident the doctors had a great learning time and hope you had a great time with us too, sir. And it was just lovely having you back and really hoping to see you soon on Netflix. Thank you, sir.
Very, very nice session. Thank you very much. Bye,
Thanks.
everybody.